But yeah, people will start coming in, and then we'll get started right around the hour. So give you a few minutes to kind of just get ready to get started. All right, Dr. Ashkar, are you ready to get started?
Yes.
All right, for the sake of time, we'll go ahead and get started. We may have some people still logging on right now, but welcome today to our internal medicine grand rounds. I'm Ahmad Rana, one of the chief residents in internal medicine here at WashU, and today we're joined by Dr. Motaz Ashkar with the Division of Gastroenterology. He's an assistant professor of medicine here at the Washington University School of Medicine. Dr. Ashkar received a medical degree at King Abdul Aziz University and completed his residency at the Stewart St. Elizabeth Medical Center, a Tufts University School of Medicine in Boston, Massachusetts. And for his outstanding performance during residency, he was recruited to serve as a chief resident for a year. He then found his way to St. Louis to complete his fellowship in gastroenterology here at WashU. Given his clinical interests, he then pursued and completed advanced fellowship training in medical pancreatology at the Mayo Clinic in Rochester, Minnesota. He then turned over to WashU in 2020, fortunately, to join the Division of Gastroenterology, where his major clinical and research interests involve the diagnosis and management of pancreatitis, with many primary focuses, including drug-induced pancreatitis, autoimmune pancreatitis, and pancreatic cancer screening in high-risk populations. And today he's going to speak to us about autoimmune pancreatitis with an overview and perspective. So with that, I will let him get started.
Thank you, Ahmad. This is such a great opportunity to participate and be invited and honored to be part of this academic activity with the Department of Medicine. grand rounds. The talk title is, as you know, Autoimmune Pancreatitis. I'll have a historical overview and perspective. See, my screen is moving. I have no disclosures. However, I've invited one of my mentors from MD Anderson, Dr. Suresh Chari, who contributed so much to the diagnosis and the understanding of autoimmune pancreatitis. And I thought it would be unfair to give a talk without having him among the audience. The outline of my talk will cover understanding about what is autoimmune pancreatitis and give a chance to differentiate between the types. Also look over the clinical presentation of autoimmune pancreatitis, bridging between clinical suspicion and how we diagnose it as well, and then eventually understanding how we treat it. Then I'll be covering the history of autoimmune pancreatitis and how we discovered it, and eventually a few slides about mimickers for autoimmune pancreatitis and how can we tell them apart compared to autoimmune pancreatitis. So there were early observations of chronic pancreatitis in the 1700s by Thomas Cowley, who thought that there is a link between lifestyle and pancreatic diseases. But in the 1800s, Klipps was the first to report a case of hemorrhagic pancreatitis, up until the 19th century, when it was thought that probably bacterial infection can contribute and cause acute or chronic pancreatitis. Later, Dr. Comfort from the Mayo Clinic in 1946 was the first to describe a link between alcohol and chronic pancreatitis. A quote from his paper in New England Journal of Medicine: "It remains an enigmatic process with uncertain treatment." Chronic pancreatitis means progressive fibroinflammatory pancreatic syndrome that results in irreversible changes within the pancreas at both ductal and parenchymal level. Typically, it can cause pain or loss of the glandular function of the pancreas. But up to the 1984, this diagnosis was based on clinical, functional, and histological evidence. And the reason why it was 84 because of the Cambridge classification that was utilized through ERCP. However, there were limitations there, as this definition did not cover causes, early disease, and resulted in some delay in treatment advances and prevention. Therefore, there was a new adopted definition in 2016, which they sort of expanded on the morphological changes seen in the pancreas to cover atrophy, fibrosis, ductal changes with strictures, and evidence of calcifications. In addition, they added more data by elaborating on causes by including genetic, anatomic, and environmental risk factors. Chronic pancreatitis accounts for about 56,000 hospitalizations annually in the United States. It basically has an incidence of 50 per 100,000 adults based on recent data from 2020. This is kind of inflated by case coding, as a lot of cases are being named chronic pancreatitis while they're not. And it's more predominant in men, with difference in epidemiology across the year from multiple retrospective data that goes up to 40 per 100,000 based on Mayo Clinic chart review data from 2006. But as I said, it has male predominance. Severe disease is more noted in African Americans compared to white. And at high level, there are two types of chronic pancreatitis. Either you have a large duct disease or a small duct disease. The etiology of chronic pancreatitis was classified in different mnemonics, but the one that's sort of practiced more is the TIGAR-O, which each letter represents a category. T stands for toxic. That would include your typical alcoholics or those who would smoke a lot, hypertriglyceridemia, medications, and toxins. And I stands for idiopathic, either early disease or late onset disease. And then genetic from G, that's different genes, primarily 6 genes that we test for. And then autoimmune, there are 2 types, type 1 and type 2. Recurrent and severe, that would result in chronic pancreatitis, either by post-necrotic, ischemic, or post-radiation. Obstruction can also cause chronic pancreatitis downstream. So what is autoimmune pancreatitis? It's a distinct form of chronic pancreatitis characterized by clinically frequent presentations with obstructive jaundice with or without a mass on cross-sectional imaging. And this has dramatic response to steroids. And histologically, it will show specific dense lymphoplasmacytic infiltrates in the pancreas that results in fibrosis. Over the years, there were different mechanisms that were sort of proposed to explain the causes of autoimmune pancreatitis. Some data from Japan suggested genetic predisposition by association with HLA mutations, but unfortunately, this could not be validated in a different cohorts from the Korean population. Autoimmunity, that's pretty much driven by the fact that in these folks, there is positive ANA, positive carbonic anhydrase 2 antibodies, rheumatoid factor and lactoferrin antibodies in a lot of the patients, which in fact primarily directed towards enzymes production, and that would explain why the ductal cells within the pancreas are unlikely to be involved as much as acinar cells, which can result in pancreatitis. In addition, this could explain involvement in extra pancreatic disease from autoimmune pancreatitis, because some of these organs could produce amylase as well as the salivary glands. And then at one point, there was a thought about bacterial infection triggers that results in molecular mimicry. So some researchers have looked into a link with H. pylori, as it can induce an immune reaction that would produce antibodies against plasminogen binding protein of H. pylori, which can also attack the pancreas in the form of molecular mimicry. All those triggers will eventually result in an immune reaction mediated by T cells, and that would result in release of interleukins as well as tumor growth factors that would cause a lot of rush of immunoglobulins and result in fibrosis. Deposition of immune complexes will result in organ dysfunction, while infiltrates with these cells into the organ will result in enlargement of the organ. So there are two subtypes of chronic autoimmune pancreatitis. Each have a distinct histological and clinical profile. Type 1 is a systemic disease that involves multiple organs, while type 2 is a pancreas-specific disorder, and there is much less data known about this particular subtype. Be aware that autoimmune pancreatitis is a rare condition. The prevalence is less than 1 in 100,000. About 4 to 5% of cases as reported on annual basis as causes of chronic pancreatitis within the at least Far East data. So type 1, basically, as I said, is a pancreatic manifestation of a systemic disorder driven primarily by infiltrates of IgG4 cells that is characterized by multi-organ involvement. Typically, there is a very distinct histology in the pancreas. There is serum elevation in IgG4 level, and there is lymphoplasmacytic infiltrates with abundance of IgG4 positive cells. These patients, they respond dramatically to steroids, and typically we see type 1 in older men, basically above the age of 60. And as I said, the predominance is for men. In the past, multiple conditions were thought to be kind of isolated autoimmune diseases, happened to be later discovered to be caused by IgG4 mediated disease, such as sclerosing cholangitis, retroperitoneal fibrosis, periaortic inflammation, and also enlargement of the salivary gland, as well as interstitial nephritis. So type 1 has a very distinct histological definition as lymphoplasmacytic sclerosing pancreatitis, or what we call LPSP, without gel lesions or granulocytic epithelial lesions. In type 2, it's basically not a systemic disorder. This is a pancreas-specific disease. It's not linked to IgG4, basically serology for the most part, so it lacks serological biomarker. There's no organ involvement. Seen more in association with IBD, mainly ulcerative colitis, in up to 30%. Tends to occur in younger patients, and again, it responds dramatically to steroids. This is a pancreaticogram picture from ERCP showing ductal changes within the pancreas with multifocal stricturing disease. Histologically, it is defined as idiopathic duct-centric pancreatitis, or IDCP, and this is the type that has gel or granulocyte epithelial lesions. When they present, when patients present, if they have underlying autoimmune pancreatitis, they would either have pancreatic manifestations or extrapancreatic manifestations, which is basically the most common presentation in type 1. Pancreatic manifestation could be acute or could be late. In an acute setting at the pancreas level, at least 2/3 of those patients will present with painless jaundice, up to 75%. On scan, you will see diffused enlargement of the pancreas with maybe with or without a pancreas mass, or you could see a variant enlargement in the pancreas in a segment that is focal. And one thing to note that very unlikely that autoimmune pancreatitis presents with your typical classic acute pancreatitis manifestations with necrotizing disease causing lots of pain and narcotics dependence. These folks also are unlikely to have marked cachexia or alarm symptoms per se. And if it's the case, then we should also think of other causes. The two cuts that you see from the CT scans, the one on the top shows diffuse enlargement of the pancreas gland, or what we call sausage-shaped pancreas, that's featureless. While in the second picture, you would see primarily focal enlargement in the tail region of the pancreas. Manifestations that could be late at the level of the pancreas could include persistent pancreatic mass lesion that would result in segmental pancreatic atrophy, as well as ductal dilatation, which could mimic underlying pancreatic cancer. And later on, as you see in the second image at the bottom, you would see significant pancreatic atrophy, which can be seen in 1/3 of those patients, which will result eventually in glandular dysfunction, either by endocrine or exocrine insufficiency. So about 35% of patients with autoimmune pancreatitis, both types, could present with pancreatic atrophy, and obviously almost the same number of the same percentage will be seen at both glandular dysfunction levels, either endocrine or exocrine. It tends to be seen more in patients who are older, in females, or those with underlying type 1 disease. Granted, if the patient has a burned out pancreas or there is pancreatic atrophy, it will be hard to see if they would respond to therapy and that would reverse their function. If the pancreas cell is lost in the essence, if the pancreas tissue is lost in atrophic, then response to steroids or immunomodulators might be less obvious. In addition, it'll be extremely hard to truly diagnose the underlying etiology of why the pancreas became atrophic. So type 1 mainly presents with extrapancreatic manifestations, and they're multiple. So patients might have biliary strictures that are multifocal or one long stricture, or they might have interstitial nephritis, as you see in the CT scan, with multiple lesions in kidneys, or in the top right image, you would see retroperitoneal involvement surrounding the aorta with soft tissue. Those patients might have seronegative Sjogren's syndrome or diffuse lymphadenopathy. In addition, it's almost important to distinguish that in autoimmune pancreatitis, there is no direct correlation with conditions such as rheumatoid arthritis or seropositive Sjogren's disease or psoriatic arthritis. They're totally separate, but maybe with autoimmunity, they could coexist. On imaging, I covered that a little bit earlier. So on a CT scan, you within the parenchymal level, you might see diffusely enlarged pancreas that has featureless borders, but also there's a pathognomonic and highly specific finding of what we call halosign, or sort of a pseudocapsule, as you see in the bottom cut of the CT scan that surrounds the pancreas. There's distinct delayed enhancement on contrast cuts, and that might be seen with delayed enhancement, especially in a T2 image with differences in perfusion if you look at MRIs. This is very almost pathognomonic in cases of autoimmune pancreatitis, and yet this can be diffuse or a focal disease. While on MRCP or ERCP, you might see different ductal changes. Either it could be a diffuse long stricture within the pancreatic duct, as you see on the top image of the MRCP sequence, almost loss of the pancreatic duct in the head to neck region. And in the second picture in the pancreatogram through ERCP, there are multiple beaded strictures across the level of the pancreatic duct. So EUS or endoscopic ultrasound is a great tool that would help us identifying particular features that might be seen also in autoimmune pancreatitis. So you might see diffused hypoechoic enlarged gland with non-dilated pancreatic duct, as you see in panel A, or you would see a mass lesion that's hypoenhancing with compressive effect. In this particular view from EUS, you see dilated common bile duct and portal vein. Findings of classic chronic pancreatitis are less witnessed. You will see less pancreatic cysts, unlikely to see a lot of lobularities, but in 43% of patients, there's a high chance of surrounding lymph nodes. So at the level of histology, LPSP has 4 distinct characteristic features. First, the dense infiltration of plasma cells and lymphocytes, particularly periductal. You might see storiform fibrosis, venulitis because of lymphocytic and plasma cell infiltrate surrounding veins and arteries, primarily veins, resulting in obliteration of the affected veins, and then abundant IgG4 positive cells of more than 10 cells per high power fields. This is a true cut biopsy from a patient with autoimmune pancreatitis showing lots of lymphocytes and plasma cell infiltrates, while this is when we see surrounding infiltrates around veins or obliterative phlebitis. Again, in type 1, high chance that we would see a lot of immune staining with IgG4 cells. While in a type 2 case, there are 4 characteristic features. The one that's quite important and characteristic is gel. And these are intraepithelial neutrophils that are primarily deposited around medium or small ducts, as well as pancreatic acini that would lead in destruction and blockages within the ductal lumen. Similar to LPSP, these cases might have lymphocytic infiltrate, and in addition to storiform fibrosis, and almost none of the cases will have positive immunostain for IgG4 plasma cells. So if you look at D, picture D, this is a classic gel in the duct of a patient with type 2 or IDCP autoimmune pancreatitis. How about serology? So the most commonly used is serum IgG4. The story started with the fact that, with a hypothesis that IgG4, autoimmune pancreatitis patients, they do have a polyclonal band as part of their gamma globulin. And it turned that this is essentially an IgG4. In general, this is basically the rarest of all IgG classes, only seen in up to 6%, but ironically, it was seen more in autoimmune pancreatitis, and it can be also seen in other conditions, including atopic dermatitis. So a landmark study in the New England Journal of Medicine in 2001 by a Japanese scientist, Dr. Hamano, wanted to investigate and see if this can be used in clinical practice. So they basically had 20 patients with autoimmune pancreatitis against 20 controls, in addition to almost over 100 patients with pancreatic cancer, and measured their IgG4 level, which showed significant increase in IgG4 level in what they called at the time sclerosing pancreatitis compared to normal subjects with a level of less than 60. And in fact, those patients showed dramatic response to their IgG4 level when they were treated with steroids or immunomodulators. Later on in 2007, Dr. Chari from the Mayo Clinic group wanted to take this up a level and understand at what level we're likely to have specific results that would give us more confidence that we're dealing with autoimmune pancreatitis, and try to distinguish between autoimmune pancreatitis and other conditions. So when they've used the cutoff level of 140, which is less than twofold elevation in IgG4 level, the specificity was 90, but the sensitivity was in the 70s. But when you use a cutoff of 280, which is basically more than twofold elevation in IgG4, serum IgG4 level, then sensitivity will drop with, again, high specificity. Granted that this was a great finding, especially that in most other cases, either benign and malignant, there were less than twofold elevation IgG4 level. However, in cases of pancreatic cancer, this was seen in about 10%, and unfortunately in about 1% in cases above twofolds above the higher normal value. So it's an imperfect test, but can be extremely helpful in the diagnosis. And later on in 2009, an Italian group looked at other serological markers, namely antibody against plasminogen binding protein, or anti-PBP. And they've used a cutoff of 32,000 international units in their NEGM paper. And that showed great sensitivity and specificity compared to IgG4 level of more than 90%. And in that particular study, they had also a training group and a validation group, which showed positive levels that are less than that threshold in pancreatic cancer and other non-malignant pancreatic conditions. And in autoimmune pancreatitis, it was seen in about 95% compared to only 10% with pancreatic cancer cases. When we treat autoimmune pancreatitis, our goal is to get complete remission, which means fulfilling the following 4 criteria. First, resolution of clinical, radiologic, and biochemical evidence of inflammation in the pancreas or other organs. By biochemical, I'm talking about normalization of LFTs, not IgG4 level. Also, absence of inflammatory lesions of follow-up. And then patients would remain in remission when we discontinue all therapies. That would include medical or basically mechanical, such as biliary stents. And it's not a hard rule to normalize IgG4 to basically achieve remission, but you're likely to see reduction in the level if the patient is truly responding to treatment. This is a series from the UK, published in CGH in 2009, showing reduction in IgG4 level, even in cases where they had relapse. While in another series from a Japanese group showed distinct morphological improvement in the pancreatic duct before and after therapy with steroids, and almost normalization of the duct caliber to normal after treatment. So for treatment, we start with induction therapy, and that's basically steroids, and that's the mainstay of treatment. There are 2 ways of doing it. Either you could do a weight-based or a fixed dose by giving a patient up to 40 milligrams a day for about a month and taper by 5 milligrams per week. Or you can use a steroid-sparing agent, azathioprine, 6-MP, or mycophenolate mofetil. Those doses were basically adopted from literature that that kind of looked at therapy in autoimmune hepatitis. And then last, rituximab. Rituximab dose is primarily adopted from an open label study by Dr. Topazian from Mayo Clinic, as well as efforts with Mass General. They've used the rheumatoid arthritis protocol by an induction with a gram over a 2 weeks period. And typically we would use rituximab if patients are intolerant to high dose corticosteroids, or if they continue not being in remission on high dose corticosteroids, or obviously if they fail to respond to other immune therapy, but also can be considered in patients who are considered a high risk for relapse at the time of their induction therapy. Maintenance, basically, we can start with steroids, and that would be between 2.5 to 10 milligrams of prednisone per day for up to 3 years, or a steroid-sparing agent for the same period, or rituximab over 2 years. And induction doses would go every 6 months for 2 years. So that's about 6 different cycles. Indications for maintenance therapy is primarily for those who are high risk for relapse or after relapse, or and this is a practice variation. Autoimmune pancreatitis is not an Asian or a Western population entity, but those experts from different areas, they practice differently. So maintenance therapy has been utilized more in the Asian population as opposed to the Western countries. Rituximab maintenance therapy is a great way of achieving remission. In 2018, Shaunak Majumdar from Mayo looked at their data in terms of rituximab maintenance therapy and achieving remission compared to those who did not receive maintenance. They've noticed that those who were on maintenance for up to 3 years, they've had relapse in almost only 11% compared to 45% in those who were not on an induction on maintenance. In addition, there was significant reduction in alkaline phosphatase level, which suggested that biliary involvement was also less over time in patients who were on maintenance therapy with rituximab. Patients could be at high risk for relapse if they have proximal bile duct involvement. By proximal, I'm looking at a level above the intrapancreatic common bile duct, or if they had diffuse swelling of the pancreas at presentation as opposed to focal enlargement. Those patients who were sent for surgery because the diagnosis was unclear and ended up with Whipple had less relapse over time. Most of the cases when they relapse in the proximal bile duct or in the pancreas. And if there's a relapse, then we start with high dose steroids followed by maintenance treatment, or start with rituximab induction. The utility of other treatments such as cyclophosphamide, methotrexate hasn't been looked at in large series, so it's unclear to us whether it's effective or not. So how did it all start? Basically, in 1961, Serology described pancreatitis associated with hypergammaglobulinemia that was not associated with alcohol consumption and suggested autoimmunity at that point. Later in 1992, the Japanese Pancreas Society wanted to classify or put clinical criteria for chronic pancreatitis. 3 years later, in 1995, Yoshida from Japan published the first case report that kind of brought up the concept of autoimmune pancreatitis. And between 1995 to 2002, there were more cases of what was thought to be autoimmune pancreatitis only in Japan, which was at that point, it was thought that this is only unique to the Far East. So therefore, in 2002, the Japanese Pancreas Society decided to put the world's first diagnostic criteria of autoimmune pancreatitis, and they mandated particular imaging findings of diffused enlargement of the pancreas, in addition to diffused narrowing or long pancreatic stricture of more than 1/3 of the pancreatic duct, in addition to one of the following, either positive serology or biopsies confirming lymphocytic infiltrates in addition to fibrosis. In 1999, Dr. Chari, first clinic patient with autoimmune pancreatitis was seen. And at the time, this was an elderly man who had 2-week history of obstructive jaundice with weight loss, an imaging of diffuse hyperechoic pancreas, and possible mass lesion. No surgery was offered to that patient because the diagnosis was not clear. But he thought of, could this be autoimmune pancreatitis? Eventually, the pancreas became atrophic. And the question that he raised, can this occur in the West? It was known that this is only seen in Japan or Korea. So Therefore, between 2001 and 2002, the Mayo Clinic reviewed pathology and histopathology from pancreatic resections for patients who were suspected to have pancreatic cancer with obstructive jaundice, but eventually ended up with chronic pancreatitis and no cancer. They classified the patients into either alcoholic, like typical alcoholic chronic pancreatitis, or idiopathic chronic pancreatitis. Two pathologists, they were blinded to the diagnosis, they reviewed the slides, and luckily one of them was actually a Japanese pathologist who had slides of LPSP with them. So when those slides were reviewed, the idiopathic group had two distinct histologic patterns: the typical LPSP in addition to the idiopathic duct-centric chronic pancreatitis. The conclusion from that was that autoimmune pancreatitis is the only cause of chronic pancreatitis that has a distinct histopathology that even a pathologist blinded to clinical diagnosis can identify. Also, that histopathology is the gold standard for the diagnosis. Histologically, at least there are two patterns, IDCP and LPSP. And this resulted in a detailed review of clinical data, including imaging studies of both cases, LPSP and IDCP. Then a team was recruited to sort of put criteria to diagnose and better understand autoimmune pancreatitis, including pathologists, radiologists, and endosonographer to do true biopsies. And surgeons also made aware of that entity. In 2006, it was the birth of the high-sort criteria. It was by Dr. Chari. It was thought at the time that features of autoimmune pancreatitis were not included in the Japanese criteria. They did not include basically serology, meaning IgG4 level. They did not include other organ involvement or response to steroids. So therefore, that group proposed an expanded diagnostic criteria, namely high-sort criteria, with a cohort of histologically confirmed, that was validated in a cohort that was histologically confirmed to have autoimmune pancreatitis. And that needed basically the following cardinal features. There are five. At the histology level, you will see classic LPSP findings. On imaging, you'll see typical features of diffusely enlarged gland with diffusely irregular main pancreatic duct, but also focal pancreatic mass lesions with signs of chronic pancreatitis can be seen. Serology, we're looking at least elevation of IgG4 level more than twofolds. Other organ involvements, including biliary ducts, retroperitoneal fibrosis, salivary glands, or lymphadenopathy. And then response to steroids, that would mean resolution with marked improvement of the pancreatic and extrapancreatic manifestations after therapy. Based on the performance of this criteria, they identified different diagnostic combinations to suggest a diagnosis of autoimmune pancreatitis. And this would include one of the three. Either you would have diagnostic histology or typical features on CT scan with elevated IgG4 level, or response to steroids therapy, which I will cover more in the next slide. So response to steroids requires the following, at least based on the high-sort criteria, and they all should be fulfilled. Unexplained pancreatic disease after negative workup for known causes such as cancer, elevated IgG4 level, and resolution or marked improvement in the pancreatic or extrapancreatic manifestation of steroid therapy. The reason why this was brought up is the fact that we cannot use steroids alone to justify improvement that is caused by only autoimmune pancreatitis, as other pancreatitis could improve on their own, and we don't want to miss underlying cancer. Between 2006 and 2008, there were some changes in the criteria in Japan and Korea. In 2002, the Japanese criteria failed to diagnose segmental disease and required revision in 2006. And also they wanted to add IgG4 level. So therefore, you see that they added the word localized instead of just only diffuse. They've added IgG4, and they've also added the word segmental narrowing of the duct as opposed to only diffused narrowing of the main pancreatic duct. And later on in 2006, also the Korean published their own criteria that wanted to mirror high sort and permit diagnostic use of steroids. And in 2008, the Japanese and the Korean met, and they finally agreed that 2 weeks diagnostic trial of steroid therapy can be utilized. This was only suggested in patients fulfilling imaging findings compatible with AIP, but with definitely complete negative workup results for pancreatic biliary cancer. A summit in 2008 in Korea included experts or pancreatologists from all over the world, tried to bridge between the aging criteria and the Mayo Clinic criteria. And at the time, Chari proposed the terms AIP1 and AIP2, given the fact that they're distinctly different on histopathology. But unfortunately, no consensus were reached in terms of development of a final diagnostic AIP guideline up until later in 2011, when they all met again in 2010, actually, in Japan, and they proposed the international consensus diagnostic criteria for AIP to safely diagnose AIP and avoid misdiagnosis of pancreatic cancer. And this pretty much depended on the 5 cardinal features used from the Mayo Clinic criteria, but again, with the caveat that response to steroid therapy is an optional criteria. They suggested that some of these criteria could be a level 1, others could be a level 2 finding, and that would kind of impact on the diagnostic reliability. The diagnosis can be definitive or probable, and sometimes it could be impossible. So not to cover this busy slide, but this is essentially a table from the actual consensus guideline of how we can utilize different sets of criteria to sort of inform about possibility of underlying autoimmune pancreatitis, at least in this case, type 1. There are different level features within the imaging part that would include ducts and the parenchyma changes, also serology, either whether it's more than 2 folds or less than that, other organ involvement, either by imaging or by histopath. But also the classic features of LPSP on core biopsies when it comes to histology of the pancreas is also key. Granted, the response to steroid, by that I mean radiological or resolution or improvement in the pancreatic tissue with over a 2-week period was again considered, but that would, but all physicians who are utilizing this method should ensure not 100%, but 200% that there is no underlying pancreatic cancer or misdiagnosis. So the combination of these criteria will eventually give us understanding whether these patients truly have definitive type 1 autoimmune pancreatitis or probable autoimmune pancreatitis. So if you look at probable and you look at the response to steroids, that would indicate at least IG4 level of less than 2 folds, in addition to other organ involvement. In addition to that, they should respond to steroids, and that would give us a sense that this might be a type 1 autoimmune pancreatitis. Type 2 is a different case. It's a much difficult disease to diagnose, given the absence of serological marker, and almost always we're in need for histology. And that's basically when we need actually ductal cells to look for gel. These patients, they don't have extra pancreatic manifestations as well, which would make it harder. So the use of steroids in this particular subset of autoimmune pancreatitis, again, should be considered if we are unclear about the diagnosis, and this might be probable, and that would also require the presence of inflammatory bowel disease. So essentially, definitive diagnosis of type 2 requires typical findings on imaging, and in addition to that, histology confirming the disease, while probable will require some histological changes, such as just lymphocytic infiltrates, in addition to evidence of inflammatory bowel disease, in addition to response to steroids. outside of that, this cannot be specified as autoimmune pancreatitis. So in a clinical encounter, when you have a patient with autoimmune pancreatitis or a patient who presents with obstructive jaundice and pancreatic enlargement, the first thing you want to look for is basically making sure that we're ruling out cancer. If there is clear, distinct features of autoimmune pancreatitis, at least level 1 parenchymal finding, then we need to basically add the collateral evidence by assessing the IgG4 level, and you might end up with biopsies from the ampulla or other regions if there is extrapancreatic involvement with the disease to sort of add that histology piece to sort of suggest the diagnosis. If it is the case and it's suggestive, then go ahead and treat. But also when you reassess, you will repeat all the biomarkers, including CA19-9. And if there is response, then this is more likely to be AIP1. If there's no response after 2 weeks, then it is key to reconsider the diagnosis. If this is not typical for AIP1, then you will likely follow an algorithm that will take you through whether this is a type 2 or not, which will require a tissue biopsy, a core biopsy, not FNA. And if it's positive and it's definitive, then we have a diagnosis. If it's not, then probably you might add more imaging study that would include endoscopic pancreatogram. So you could do ERCP, you could do MRCP and look at the ducts. If you see ductal changes that might be consistent with autoimmune pancreatitis, then steroid trial before we reassess, and that would give us a 2 weeks window to understand whether this is the disease or not. And this will need IBD presence as well. Otherwise, it cannot be specified as autoimmune pancreatitis. So how about autoimmune pancreatitis and other mimickers? So mainly pancreatic cancer. In 2009, Chari and Bege looked at basically features that would kind of distinguish between autoimmune pancreatitis and pancreatic cancer. And they examined CT images, IgG4 level, histology data, and response to steroids between patients who were found to have AIP and those who were found to have pancreatic cancer. In the retrospective data, they have grouped them into 3 different groups: those with highly suggestive features of AIP, those with indeterminate features of AIP, either a normal pancreas or focal pancreatic enlargement with no clear, distinct cancer features. And the third group basically are those who are highly likely to have what appears to be a cancer with a low density mass, pancreatic ductal cutoff, or upstream pancreatic atrophy. So if there is diffuse enlargement of the pancreas or with a capsule, almost 100% specificity that this is autoimmune pancreatitis. As you see, most of the cases were only seen in, or all cases were seen in autoimmune pancreatitis, and none of those patients had pancreatic cancer. But if there's focal enlargement, as you see in the first cut on the CT scan on the top, there is only focal enlargement of the head of the pancreas, or you would see, or if there is some form of atrophy or mass effect, then this can be seen in pancreatic cancer patients, but still it was very specific for autoimmune pancreatitis. However, when there is a low density mass lesion with pancreatic atrophy distal to it and dilated pancreatic duct, then there's a high chance that this is pancreatic cancer, but still this can be seen in autoimmune pancreatitis patients, not as common. So the sensitivity is pretty low when we look at those radiological features to say this is AIP as opposed to pancreatic cancer. As far as histology and, as far as serology, IgG4 was seen almost in all patients with autoimmune pancreatitis, none in pancreatic cancer if the level was more than 2-folds, but in 10% of patients with pancreatic cancer, they had elevated IgG4 level of less than 2-folds, so more than 140 to 180. So the conclusion is, first, we need to exclude pancreatic cancer if you're trying to investigate for an enlarged pancreatic gland. Obstructive jaundice with a diffusely enlarged pancreas, especially with a capsule-like rim without dilated duct or cutoff or a low density mass, will be likely highly suggestive of AIP. These features low density mass, pancreatic ductal dilatation with cutoff and atrophy are more and more typical with pancreatic cancer. And if someone is almost confident that this is not pancreatic cancer, then yes, they can be seen in autoimmune pancreatitis, but obviously very less common compared to the first set of radiological criteria. Elevation in serological marker is not sufficient to make a diagnosis of autoimmune pancreatitis. Then how about autoimmune pancreatitis and primary sclerosing cholangitis? So two Japanese case series from 2004-2005 examined that through cholangiogram findings by looking at the length and the region of a stricture formation within the bile ducts. And they've looked at their groups of PSC against IG4 mediated sclerosing cholangitis. And they have found that band-like strictures in the bile ducts are more seen in PSC. Beaded appearance is more seen in PSC, while a long segment distal pancreatic common bile duct, is somehow more common in sclerosing cholangitis by IG4 mediated disease. Also, in sclerosing cholangitis with AIP, there is a high tendency for these patients to be older men, and they typically present with obstructive jaundice as opposed to PSC, secondary to abrupt disruption of the distal common bile duct. All patients in that case series had chronic pancreatitis, and none with PSC had any pancreatic findings. In addition, there is significantly high level of total bilirubin or hyperbilirubinemia in IG4 mediated disease, indicative of an abrupt obstruction of the bile duct. And those patients also had significantly elevated IG4 level. They've concluded that abrupt obstruction of the common bile duct will result in obstructive jaundice. That is more seen in biliary involvement with an IG4 mediated disease as opposed to PSC. The most prominent feature on cholangiogram would be stenosis of the lower bile duct. Patients are older and more commonly seen in men. IG4 level was significantly higher in autoimmune phenomena as opposed to PSC. And one of the other most important features is that these folks, they tend to respond better to biliary drainage and steroids therapy as opposed to PSC patients. Some unanswered questions that I think are great to investigate in the upcoming future would be, do we know or not that steroids would alter the natural history of the disease? If yes, what's the safe window? The other thing is that the long-term of risk of cancer in those organs affected by autoimmune pancreatitis is unclear. A large multi-center case series from basically Europe, the US, as well as Asian groups, I believe included 23 centers with almost 1,000 patients with confirmed autoimmune pancreatitis, did not see clear evidence that there is correlation between cancer and autoimmune pancreatitis. But in the Asian cohorts, they had more gastric cancer, which more likely related to increased screening by imaging and endoscopy as opposed to correlation with the autoimmune pancreatitis. When it comes to type 2 or IDCP, as I said earlier, this is more common in the IBD group. So is this an extraintestinal manifestation of IBD, or is this some form of related autoimmunity? I think it's unknown. And then maybe in the future, we'll come up with a serological marker for type 2 that would help us getting to the diagnosis, since it's highly dependent on histology. So in summary, type 1 autoimmune pancreatitis is a multi-system disease, while type 2 is not. There are 5 coronal features that can help us diagnosing autoimmune pancreatitis. Steroid trial is not to be used as an alternative for a good thorough search for etiology. This is a table that kind of compared the two types. So a type 1 will commonly be seen in an older individual as opposed to type 2, predominantly seen in men. serum IgG4 level is significantly elevated in type 1, can be, but very less likely to be elevated in type 2. Type 1, you'll have pancreatic manifestations or involvement, while this is not the case in 2. IBD is more common in type 2, up to 30%. On histology, both will have lymphoplasmacytic infiltration with periductal inflammation, but granulocyte epithelial lesion is more pathognomonic and characteristic for type 2. IgG4 staining is more to be seen in type 1 and almost rarely seen in type 2. Both will respond to steroids by over 90%, but most importantly is that the relapse rate is over 50% in cases of type 1 as opposed to type 2. One last thing is that conservative treatment was proposed in one of the Asian practices, but unfortunately, the relapse rate is obviously higher in both cases. So if a type 1 patient is not to be treated and we decide to go with conservative management, chances of basically improvement upfront is about 50%, but relapse will not be the 60%, it's almost close to 80%. In the type 2, more likely for them to respond without any treatment, but relapse instead of a 10% will be around 50%. Thank you again for the opportunity. Happy to take any questions, if any, and good luck with everything.
Thank you so much for a wonderful presentation, Dr. Ashkar. There are a few questions, and so I will go ahead and go through them right now. So the first one says, thank you for a wonderful and comprehensive overview of AIP. We know that PSC has a large overlap with IBD, and I was wondering what is known about the genetics of patients with IgG4 and AIP in the background of PSC/IBD. Is this a distinct genetic subtype of PSC?
Well, thank you for the great question. So genetic predisposition in autoimmune pancreatitis, as I said, hasn't been successfully validated. This came from the Japanese cohorts at the very beginning of the basically discovery of this condition in the early 2000s. They thought there is link with HLA mutations, and that would increase the susceptibility, but no validation in Korean studies after the fact. I'm not aware of any basically additional genetic variations in the subset of patients who are likely to have underlying IBD. So the answer is, I don't know if that data exists yet.
The next question is, in patients who relapse after steroid initiation, what % will relapse after a second round of steroids? And would the practice now include rituximab following the failure of steroids?
Yep. So I'm sorry, is that for type 1 or type 2?
It does not specify in the question.
Okay. So for type 1, it's, I mean, if you give a patient a round of steroids or any form of induction treatment, relapse is 10% or less. They almost do not relapse. At one point, actually, this was debated whether it's an autoimmune disease or not. Type 1, they tend to relapse more often, in more than 50% of the time. So it's different in the past before rituximab. With rituximab, if you put them on maintenance, it's less than 11%, as opposed to no maintenance of 45%. This is definitely much better than an immunomodulator, which would include azathioprine. Those patients can relapse in about 70% in their second round.
All right, just a couple more questions. So more about triggers. Could viral infections trigger AIP, and are there other known trigger factors for this autoimmune disease?
So I did not see any data about viruses that would induce AIP.
And then can recurrent bouts of pancreatitis lead to the development of autoantibodies?
I'm sorry, say that again.
Could recurrent bouts of pancreatitis lead to the development of autoantibodies?
You mean an idiopathic recurrent acute pancreatitis?
Not 100% sure what the, yes, it is clarified that that is the question.
Yeah, they're totally different diseases. Idiopathic and autoimmune, they're totally different diseases. This trigger or autoantibodies in autoimmune pancreatitis has been debated whether this is, again, linked to the disease or essentially autoantibodies are being formed in the setting of an inflammatory response. So unclear. And that's why we do not typically rely on ANA, RF, or other autoantibodies in the diagnostic criteria of AIP. And this is, again, in a case of idiopathic recurrent acute pancreatitis, I would expect if you check ANA level for it to be positive, but it does not mean much.
All right, and I think this will be our last question, but this is a follow-up to the first question about PSC. Is there an increased incidence of colon cancer in patients with both AIP and IBD?
Yep. So the answer is no clear data thus far about cancer risk in association with autoimmune pancreatitis. So I don't think in a patient who has underlying IBD and AIP that the cancer risk would be higher. Their cancer risk is highly dependent on their obviously inflammatory bowel disease status as opposed to their AIP status. So based on the Asian cohorts, the most common was gastric cancer. I've seen reports about pancreatic cancer in less than 5%. There were some reports about lymphoma as well, but I don't think there is correlation yet. This is a question for the future.
All right, and I think those are all of our questions for now, and we're kind of running up on time. I'm gonna go ahead and share my screen. Actually, I think Dr. Ashkar, you're gonna have to stop sharing your screen so that I can share mine. So that we'll have the QR codes for CME and MOC as well as to get credit.
Okay.
Thank you so much, Dr. Ashkar, again, for a wonderful presentation. If anyone has any further questions that they just aren't thinking about right now and want to share, feel free to reach out to me, and I'm happy to get in touch with Dr. Ashkar so we can get your questions answered. And
thank you, Ahmad, and thank you, everyone.
Thanks again. Have a great one.